the opportunity. A disclosure that the slides have been provided by Novartis. So I'll be talking about the targeted treatment for uncommon mutations, relatively uncommon mutations, which is BRAFV600E and MET exon 14 mutated NSCLC. So we all know the incidence that lung cancer is pretty common in terms of incidence and mortality. And it is basically molecular driven, oncogenic driver driven treatment, whereby the largest chunk is taken by the EGFR. However, there are other mutations as well, and that very category is an unmet need. So today we'll be talking about the BRAF mutation, which as per this pie, which was according to a paper published in 2022, constituted 5.5%, and MET mutations. So MET, I'll be talking which mutations is the drug active for. So MET exon 14 constitutes roughly 3% of the mutations. So upfront molecular testing is a norm. We all are doing that, and sometimes we are doing individual genes. Sometimes we are sending the NGS panel, and NGS panel has its own strengths and weaknesses. One of the weaknesses mentioned is that it is labor and equipment intensive and requires computational biology expertise. So this is the form we are all very much aware of. We fill this form. It comprises of as many genes as mentioned on the paper, on the screen, along with PDL1 testing. This is a standard upfront workup for CA lung. We all are doing that. So moving on to BRAFV600E mutation in lung. So basically, BRAF mutation leads to constitutive activation of the MAP kinase pathway. So V600E is one of the mutations in the BRAF. There are other mutations. However, BRAF, it's the most common point mutation of the BRAF gene. So incidence wise, it varies from 1 to 5% across the world. Non-Indian data ranging from US, Europe, China, the prevalence varies from 1 to 4%. More commonly, we are aware of the US and the Europe data. So BRAF V600E is a targetable mutation, and not only is it prognostic but also predictive for the BRAF inhibitors. So we know that the BRAF mutated cancers have poor prognosis when treated with chemotherapy, and the drugs which were available before that were vemurafenib. However, now we are giving dabrafenib plus tremelimumab, and dabrafenib plus tremelimumab, as you can see on the screen, acts in a sequential manner, whereby dabrafenib is a BRAF V600E inhibitor, while tremelimumab inhibits downstream MEK pathway. So the famous study BRF113928 study, it was a 3-arm study where there were 3 cohorts. Roughly the patients were 60, 40 and 25 in the 3 arms. So cohort A was second or third line treatment of BRAF mutated cancers with dabrafenib as a monotherapy in 150 milligram BD. Cohort B was downstream second or third line with dabrafenib plus tremelimumab, and cohort C was ambitious in the form of upfront dabrafenib plus tremelimumab treatment in BRAF V600E patients. By and large, the arms were balanced in terms of age, sex, race, performance status, histology, and smoking status. And the key results in a snapshot, the response rates for monotherapy cohort A down the line was 33%. However, the response rates for the combination, whether down the line or upfront, were almost doubled to 63 to 68%. So the duration of response, by and large, single or combination upfront or down the line, is around 9 months, 9 to 10 months. The PFS is 5.5 months if we give as a single agent. Combination is almost doubling to 10 months, and overall survival also with the combination is better in the range of 1.5 years versus 1 year if dabrafenib is given alone. Mind you, the combination when given upfront or down the line as per this study had similar figures. So the key difference was not the line but the combination. So based upon these, it is approved in ESMO and NCCN guidelines, and it's there in first line treatment, subsequent treatment, both Europe and US. Reported results of efficacy. So now the point is, okay, we know that dabrafenib plus tremelimumab is superior to dabrafenib. It's superior to vemurafenib. How about immunotherapy? So immunotherapy also in BRAF, so these kind of mutations, BRAF mutations, the response rates are around 25% with or without PDL1 score being high versus almost 68% if we give the targeted therapy. So PFS, duration of response, overall response rates, all by and large favor the targeted therapy. Again, reiterating the points as in other mutations that if we have a specific mutation, inhibitor works better as compared to chemotherapy or immunotherapy. Moving on to the other medicine which goes by the name of capmatinib, Rahika. So it's approved for exon 14 skipping mutation. Now, MET oncogenic activation can occur by various mechanisms. It can occur by physiologic signaling, it can occur by MET kinase domain mutations, amplifications, fusions, and last on the screen is MET exon skipping mutation. So it is this very specific indication where this medicine is approved, and the incidence is about 3 to 4% in adenocarcinoma, NSCLC with sarcomatoid variant, squamous cell NSCLC, and sarcomatoid carcinoma as well. Again, clinical characteristics, it's more common in females, non-smokers, and it has a poor prognosis. So we again know with retrospective data, we know from retrospective data that MET14 exon mutation is having a poor prognosis in terms of survival, and specific targeted therapy when given improves the survival rate. So when no MET targeted treatment was given in a stage 4 patient, the overall survival was 8.1 months, and it almost improved to 3 times, 300% improvement when MET targeted treatment was given, with median overall survival improving to 24.6 months. So we know that chemotherapy and immunotherapy don't have that good numbers. There is some buzz about crizotinib acting, having some efficacy in MET exon 14. So the numbers are that median response rates, response rate is about 30%, and median PFS is about 7.3 months down the line. So based upon this, capmatinib is US FDA approved. It is a selective MET inhibitor. There are other MET inhibitors, but capmatinib being selective is most potent with lesser side effects. So Geometry Mono 1 is a study which basically tries to evaluate the efficacy of MET inhibitor in a situation where there are multiple cohorts, some being untreated patients and some being pre-treated patients. So treatment naive and pre-treated patients, in all the basic characteristics like race, sex, smoking, etc. are evenly balanced. And if we see the results of capmatinib in treatment naive patients, the response rates again are to the tune of 67 to 68%, fairly high disease control rate, median PFS of 12.4 months, median overall survival of 20.8 months. This is treatment naive. And if we talk about pre-treated patients, the overall survival is about 13 months and median PFS is about 5 months. Response rates again almost 40 to 50%. So there are case studies to show that capmatinib is fairly active against brain metastasis and intracranial activity is there. And in terms of side effects, GI symptoms, peripheral edema, and specifically increased creatinine, they are more to be monitored. Otherwise, by and large, class specific side effects are always there. So this chart shows the approvals, and the highlighted approvals are dabrafenib plus tremetinib for BRAFV600E and MET exon14 capmatinib, preferred in upfront setting without any chemo or immunotherapy. So this makes all the more compelling reason for us to send a comprehensive NGS, which is covering BRAF, ALK, MET, etc., and not just EGFR and ALK. So with that, I conclude. Over to organizers, Dr. Kapoor sir and Dr. Dubey.
Sir, thank you, sir. Thanks for such a beautiful talk, sir. I would like to ask you one very basic question, sir. Like there are many pharma companies who are providing free coupons for very limited NGS, or EGFR, ALK, and ROS1. And so are you going, because these are the most commonly found actionable targetable mutations. So are you going with that, or and if negative, then you are going for the other targetable mutations, or you are directly going with both DNA based and RNA based NGS for all the targetable mutations, all 8 targetable mutations upfront, sir?
So by and large, those 8 mutations are also available in a free coupon. My preference is mostly for the 8 mutations plus PDL1 upfront. However, sometimes there is limitation of tissue. So in that case, depending upon the patient profile, let's say the patient is non-smoker, adenocarcinoma lady, then maybe if the tissue is limited, I will restrict myself to EGFR, ALK, and PDL1, followed by other mutations. If tissue is not a concern, then I send the 8 gene panel. If cost is not a concern, I try to send the complete NGS comprehensive panel.
So it's not like a PDL1 you send only when the patient's negative for all the targetable mutations, or PDL1 also you will send altogether?
Basically, I am comfortable with all the information upfront. While I agree with you that we can do the sequencing by sending EGFR mutation first, followed by PDL1s, but time is also a concern sometimes. So if tissue is not a concern, then surely I'm comfortable sending PDL1 as well.
Thank you, sir. Thank you, sir.
Thank you.
Nowadays, like Pembro, probably they say that irrespective of PDL1, one can use upfront with the chemotherapy.
Sir, while I agree with you, but we have data to show that efficacy is less if there are some mutations. So I restrict myself to adding immunotherapy after I have a negative report of the EGFR, ALK, and other things. So by default mode is chemotherapy, wait for the reports, add immunotherapy in second cycle. Another reason for that is there is a case of hyperprogression also, and I have actually lost one patient in that situation. So while hyperprogression has got no bearing to PDL1 score, so I am not very, I should say, adventurous in terms of adding PDL1 inhibitor right in the front till the time I have all the reports.
I have used dabrafenib and tremetinib in one of the patients, but somehow poor prognosis, metastatic young boy, he didn't do well with the treatment. What is your experience about this?
So, sir, I have used dabrafenib not only in lung but also other places where we have some kind of mutation showing BRAFV600E. Now, while I agree with you, we know that 1/3 of patients are going to fail upfront to this medicine. But on the whole, sir, it's a reasonably well-challenged, well-tolerated drug, and this is the best we have. I mean, we know that BRAF patients will not respond to other treatments. So, I mean, we have to bear with what we have.
Okay. Thank you very much, Vikas. It was a very nice talk, and you have covered very nicely the newer drugs in the management of BRAF and exon 14 mutation.
My pleasure.
Thank you very much, Vikas.
Thank you, sir. My pleasure.